Okay, so for those of you who saw my, personal page post, you know that I tried doing this a little bit earlier today, recorded for about 40 minutes, and then when I went to go stop recording, realized, wait, I wasn't actually recording. So we're going to give it another go. I'm not going to do it for anywhere near as long. First take was 40 minutes. That didn't work, so this take's going to be about 15 minutes maybe. It's 11:30 at night. Just trying to get as much information out there as I can prior to our first study group meeting. So, getting back to it, the SI joint. Pain provocation tests are more reliable between testers than tests based on palpation or observation. Again, I'm surprised that people are still doing palpation-based testing for the SI joint. The SI joint is not a common finding in the PT clinic. There's a research article that came out, more of a summary of articles in the McKenzie Journal back in probably 2009, in which they put a little graph there which shows roughly 5% of symptoms below the buttock could be coming from the SI joint, 5% of symptoms above the SI joint or above L5 are coming from the SI joint. So the symptoms are typically right in the butt. Okay, and then roughly 13% of patients who complain of low back pain may have an SI joint dysfunction. Okay, multiple tests are better than one test, and the amount of movement at the SI joint is, quote, so minute that external detection by manual methods is virtually impossible. Yeah, when you put your hands on the patient, you become a little bit more biased as to what's going on there. You may actually believe that you're feeling motion when research shows that it's highly unlikely that you're feeling anything. I want to throw another caveat out there before I keep going. This is my presentation. This is not that of the McKenzie Institute International. These are my views. These are my experiences. This is more like a book report of the first two books of the lumbar spine. This is not endorsed by the McKenzie Institute International, so I just have to throw that out there. Okay, differential of the SI joint. Exclusion of more common causes of butt, thigh, and groin pain, such as the lumbar and hip. If you read Laslet's articles, in it he talks about performing a mechanical evaluation to determine if there's centralization or peripheralization. Centralization, if the patient's centralized, you have a high correlation with the discogenic lesion, and additional SI testing becomes irrelevant. Pain must be present at the buttock and may radiate anterior. And then your pain provocation test, these have changed a little bit over the years. Again, I first did this presentation in 2011, and all of my students that come into my clinicals are required to read this prior to starting the clinical, so that way they have an idea as to what to expect when they walk into the doors. FACET pain, you can run through and read this. There's no effective treatment had been identified as of this paper, 2013-ish. There's the clinical prediction rules for the gapping technique or the Chicago roll, or I know some schools call it the Chicago roll, some other schools call it flexion rotation manipulation. But again, you can read Flynn's study for the manipulation. Spondylolisthesis and spondylolysis. Just because they have this on a radiograph or an MRI does not mean that it's a source of pain. Roughly half of the patients with this finding do not have pain, so the finding may be unrelated to the symptom. There was another article that I read, I don't know, I'm going to guess 2010, that covered judo players with spondylolisthesis that were asymptomatic. Just because the patient shows an abnormality on imaging doesn't necessarily mean that that abnormality is the cause of pain. These patients are more likely to be painful and weight-bearing, maybe with extension, and typically surgical treatment is superior to conservative means. Usually with conservative means, what you're doing is you're bracing and you're doing, I'm going to put it in air quotes, core stabilization for up to a year from what I've seen in some of the research. Just because the extension is often painful does not mean that you don't test it. You still have to follow patient response. So don't be biased going into your evaluation that the diagnosis may say spondylolisthesis, and that for you just means completely avoid extension. you still have to put the patient through a full mechanical response. The patient has to respond in such a way that it's like an irreducible derangement, meaning that you're not making the patient better over the course of time, and then extension may produce worsened symptoms. Chronic pain, a lot of research has come out since I did this presentation. There's the SMART article on chronic pain. You've got Butler's article, Butler and Me. You've got Annie O'Connor and Melissa Kolsky's work in A World of Hurt and their publication in the Journal of Manual Manipulative Therapy. I highly recommend the book, A World of Hurt. I don't get paid to endorse the book. The only thing that I will admit to is that I may have a bias towards those two since they were part of the study group over at RIC that I was a part of for a few years. But the book is an excellent read. If you're not going to read that book, you have to understand pain science. So Explain Pain. That's a good book to read. You've got Lorimer Mosley's stuff that's out there, Butler's stuff that's out there. Adrian Lowe, I believe that's his name, has a book out there, all of this on pain mechanisms. And so you have to understand pain, specifically for patients whose pain may not respond mechanically. They'll have persistent pain, it'll interrupt their ADLs. You may see all these other things that are on there. The only thing I'm going to take out maybe is the Waddell signs, which were coming up here, yeah, just because as the research goes forward, the Waddell signs are losing favor in the research. For chronic pain, you typically get no lasting change in pain location or pain intensity. They tend to have widespread pain symptoms. All activity increases symptoms, almost like an inflammatory component, and they may have exaggerated pain behaviors. Typically, they'll have, I don't want to say mistaken pain beliefs, because they're the patient's pain belief, but we may have to try to coach them along into a more proactive pain management style, or more of an internal instead of external locus of control, meaning the patient has to start taking more ownership. I'm going to skip through those. When we look at the MDT form, I highly recommend, this is one thing I'd change from the first time I tried to record this. Before you go on with this video, just Google, you can find it at I think it was McKenzieMDT.org. Just Google McKenzie Institute and lumbar form, and I highly recommend you print it off or look at this while you're listening to the video, so that way you can see where I'm coming from. I'm going to stop after this slide also, and then we'll continue with the history maybe tomorrow or Sunday. Anyway, the first time that I took the McKenzie course, it was Part A. I had already been in the McKenzie study group for 2, 3, 4, maybe 5 months at the time, and when I was a student in the study group, I'll just give some quick stories here because this is actually, they're pretty good. It was a who's who of a study group. Bill Curtis was in the study group. Bill is one of the longest practitioners of the method in the Chicagoland, specifically the south suburbs. He's been spoken of on Mechanical Care Forum. He's my former boss. Been spoken of on the Mechanical Care Forum by Jason Ward regarding probably the most frequent attended extremities course of anybody in the country. So Bill was part of the course. Mickey Shaw was part of the course. Mickey has moved on for a doctorate in science and a fellowship, and he's credentialed. Annie O'Connor and Melissa Kolsky, I've already mentioned. I mean, their names almost go without saying nowadays. They've written the book on pain and pain classification. Dave Plevel was part of the group. Multiple credentialed and diplomat therapists. Jane Borishammer was part of the group, and if you get the opportunity to take a course with her, I highly recommend jumping into it. Ella, there's just a lot of diplomats in this study group, so I had the the privilege of learning under the best in the world in the Chicagoland area that just happened to be in the Chicagoland area near RIC. So yeah, if you get the opportunity to attend a study group, or you're in an area where there's not a study group, I'd highly recommend creating one. Anyway, getting back to this, that first study group I went to as a student, I remember sitting next to Mickey, and the patient came in with symptoms, down at the lateral epicondyle of the femur, and the pain was persistent with running, typically around 30 degrees of knee flexion, and she felt a small click every time that she ran. And, Mickey kind of leaned over towards me and he said, "So what do you think's going on?" And I was dead set. I was a student. I'm like, "That, my friend, is patellofemoral friction syndrome." And Mickey said, "Okay, from here forward, keep your mouth shut and just listen." I was wrong. I was very wrong. The patient had a relevant lateral component. She responded to side glides against the wall. She was tested again with running. Her pain abolished. At the next study group, the patient's pain had remained abolished after the evaluation in the group setting. At that point, I realized they don't teach you everything you need to know in school, and I spent probably a year to a year and a half just listening to everybody in that group and trying to understand their thought processes. And that was one of the best parts about being in that study group, was not only was I around, among the best in the world at utilizing this method, also Thomas Lotus, a chiropractor, was also in the group, doing phenomenal stuff now, him and his wife, Gina. And so, again, if you get a chance to take a course with any of these people, jump in on it, because, and again, I don't get paid to promote any of this. If you get a chance to take a course, jump in, because you're going to see some really high-level thinking. Critical thinking is one of the best things that I got out of that study group, because I had the opportunity to sit as a fly on the wall and listen to 15 to 20 of the best minds, in my opinion, arguably in the world, covering mechanical and positional issues. And so I learned a lot just by sitting back and listening. So yeah, that was the study group. Getting back to now the form, my first time taking the Mackenzie Part A, again, I had already been in the study group for a few months, and my boss, Bill Curtis, he had already taken a lot of courses. He was credentialed. He'd been to the conferences, so he was familiar with all the faculty. And he warned Scott that I was coming. I was unaware of this, and Scott, needless to say, he barraged me with questions during Part A, and really humbled me in Part A. And I thought I was walking into Part A, and I'm like, this is just a review. But he really did emphasize the need to follow the systematic assessment. And I was more gunslinging from what I had seen in the study group, and I thought I understood the system, and I had a decent grasp of it. But once I really started following the form a lot more, it became clear as to why the questions were in the order that they were in, and why they were even being asked in the first place. Nowadays, I don't go through the form as dogmatically as I did previously. I let the patient speak and tell their story, and if there are some questions that the patient may not have answered in the process of telling their story, I'll go back and ask. But that comes through, years and years of using this system and feeling extremely comfortable with just having a conversation with the patient now, as opposed to filling out every line on the form. Actually, I'm going to come back and do the history later tomorrow. It's a long day. I went to a conference today, a conference tomorrow, so I'm really just trying to get as much information as I can out before the study group next week. So thanks for listening. If you have any questions, feel free to ask in the comment section of this thread. I'll try to do a Facebook Live to answer any questions that may pop up. But yeah, thanks for watching.